Hi everyone, welcome to Surgery Dada. So today I have a very interesting topic, and this topic is again a hot favorite of every exam, every examiner, and of every hospital. As a doctor, you need it on day-to-day basis. So what is that? You must have guessed it by seeing a three-chamber bag next to me. So what is this? This is parenteral nutrition. So today we are going to talk about parenteral nutrition. So before we go into the topic of parenteral nutrition, let me tell you what is parenteral nutrition. It is nothing but delivery of the basic elements of nutrition in the IV form. So elementary nutrition in the intravenous form. Now when we talk about the three chambers, why there are three chambers? Because the basic elements are carbs, lipids and protein. So now you can guess that this is a 3-in-1. So when we talk about TPN versus PPN, or when we talk about parenteral nutrition, what are the types of parenteral nutrition we have? On the basis of the route which we are using, we have two types. One is TPN, and what is TPN? Total parenteral nutrition. This is the nutrition given via intravenous route, but from the central intravenous routes. When we talk about PPN, PPN doesn't mean partial, it is peripheral parenteral nutrition. So peripheral parenteral nutrition is given by the peripheral route. It may be a simple IV cannula or it may be a PICC line also. So this is very simple. Then based upon the concentration and based upon the, you can say, composition, we have 2-in-1 versus 3-in-1. Both TPN and PPN are available in 2-in-1 and 3-in-1. When we talk about 2-in-1, we have carbs and the proteins. When we talk about 3-in-1, we have carbs, protein and lipids. So now you can guess, dear students, what is this? This is the lipid part, this is the carb and this is the protein. So this is a 3-in-1. Now which variety it is? So you can see there is written Rio Mix Peri. So what do you mean by Rio Mix Peri? This means the peripheral parenteral nutrition. So in my hand I have the PPN. So when we talk about the basic difference, why TPN and why PPN, try to understand that this is a high concentration solution and this can cause very severe thrombophlebitis. So do you know that total parenteral nutrition, the concentration of TPN is more than 950 milliosmoles, and it is not fit to be given via the peripheral route. Even if you give within a day or two, the vein will develop a very severe thrombophlebitis. When we talk about PPN, the concentration or the osmolarity is bit less. I'll show you. Here it is written also, the osmolarity is 624. This is 624, which is the osmolarity of this solution. Now let me tell you the basic criteria for TPN versus PPN is the osmolarity of all the available PPN in the market is less than 650 and TPNs, they are 950. Now try to understand, when we talk about what is the source of carbohydrate, 5 to 10% dextrose. So now you can see that when we talk about this parenteral nutrition, it is a combination of dextrose. So you can see this is dextrose. Now one very important thing is that what should be the maximum available concentration of the dextrose? Remember, it should be less than 25% weight by volume, less than 25, because the higher the value, the higher is the risk of cholestasis and parenteral nutrition induced liver failure. So if you see in this bag, this dextrose injection is 15% weight by volume. Again, this is good. Now when we talk about the amino acids, they are all essential amino acids. When we talk about the lipids, here we have the mixture of MLT and MCT and LCT. What is MCT? Medium chain triglycerides, and LCT, long chain triglycerides. Now one very interesting thing is that why these three chambers? So these are the three chambers, and this is a bag where when you apply the pressure, the bag will always rupture into one chamber into another. So this is very important to rupture. Just see, I will show you how we rupture. Can you see it has ruptured? It has ruptured. So this component has mixed with this component now. So now we will rupture this component also. So this is the lipid component, and now you can see the lipid component has also been ruptured. So you can see all the three components have mixed together, and now this is a milky solution. Now this is a parenteral nutrition which is ready to be infused in the patient. So we have a patient presenting to us with obstruction due to Crohn's, severe Crohn's colitis. I'll make a separate video on that. So for that we have to start, because this patient is not able to tolerate anything orally. Now one very important caution that you have to understand: what are the indications of parenteral nutrition? Instead, you should remember that unless contraindicated, you should be going for the enteral route of, you can say, nutrition. When do we go for parenteral nutrition? When we have severe diarrhea, severe vomiting, severe malabsorption, obstruction, perforation. Sepsis is a relative contraindication for both the varieties, enteral and parenteral. But remember, it is absolutely contraindicated if it is the parenteral route. So if there is patient who has sepsis, you cannot start with this because of the high glycemic load. There will be nothing but flare up of sepsis. The next very important thing that we have to understand: what are the relative contraindication of the parenteral nutrition? So one I have told sepsis, another is hyperglycemia, diabetes, uncontrolled diabetes and diabetics, electrolyte imbalance. These are any form of alkalosis, acidosis, electrolyte imbalance. They're all contraindications to parenteral nutrition. Now understand most important and most common complication. This is hyperglycemia. The second is fluid overload. When we talk about fluid overload, the most important criteria is the weight gain. Weight gain more than 1 kg per day is defined as a classical fluid overload. Now what is the caution? Remember, when you are going for parenteral nutrition, electrolyte imbalance is very common, and especially hypo. Why hypo? Because first of all, there is dilution. Second is, when we talk about the insulin, which is an active component of the parenteral nutrition, it causes an influx of K+, resulting in hypokalemia also. So hypo and hyper, everything can happen. Hypomagnesemia, hypophosphatemia, everything can happen. The next very important thing is the rate of infusion of parenteral nutrition has to be slow. When we talk about the carbohydrate, it should not be more than 5 milligram per kg per hour. Remember, 5 milligram per kg per hour. Why? Because if it is more than that, this is going to cause a very severe liver failure, and that is what is known as parenteral nutrition induced liver failure. I said 5 milligram per kg per hour. It is 5 milligram per kg per minute. Sorry. Now this is very important for us to understand the basics of parenteral nutrition. Now when should we go for parenteral nutrition? Remember, if the patient has not been able to take anything for or more than 7 days, and if the enteral nutrition is not the correct route. The second thing is, when we have to choose TPN versus PPN, if you want to give a prolonged support, then go for a central venous access. If you want to give it for a short course, that is less than 1 week, then peripheral IV line is best. Why? Because the life of peripheral IV line is short, and that is why the parenteral nutritions have to be decided based upon what is the choice, what is the duration of the nutrition that is required. So I hope this video will help you understand the basics of parenteral nutrition.